I think that transforming from a fee-for-service driven system to a value-based care focused system is a bigger transformation than McDonald's going from fast food to fine dining.
Wow.
That's the level of change that it really is.
David Muhlstein is one of the few people who have helped shape value-based care from every angle: data, delivery, and national policy. From working directly with CMS and CMMI to design and evaluate alternative payment models, to helping state Medicaid programs redesign how they pay for outcomes, and leading some of the most influential research on ACO success and failure. He also built Torch Insight, a data platform used by health systems and payers to understand risk, and now runs Simple Healthcare, where he helps stakeholders actually make sense of the numbers. In this episode, we break down why most organizations fail at value-based care, how to know if your model will scale, and why social care investments only work when you fix the structure first. If you've ever wondered why your data isn't leading to better outcomes or how to make a business case for social care that actually holds up, this episode is for you. What are the conditions that will actually determine whether value-based care expands or contracts over time?
I think there's a few things that are going to influence this. The first one is how much push there is, both from the government and from the commercial sector, from the payer side. So if people need to make changes, if you have something that pushes you toward it, you're more likely to make those changes. So that's the first one, is just how much continued emphasis we see on that. And certainly the federal government, we've seen from multiple administrations continued interest in value-based care. One of the few things in healthcare that people can believe in and get around, that if you provide better care at a lower cost, then better than the alternative. And so I think that the federal government will continue at least to create models and programs for it. But we'll see how that goes in the longer term if they really start pushing people rather than just kind of encouraging. So is it a shove or a nudge is what they're doing. The second part is how successful can organizations be at effectively managing populations, creating an ROI, really achieving the goals of value-based care. You have a whole bunch of organizations that go in, invest a lot of time and resources and money, and a couple of years later throw in the towel and say, we're not going to do this. Then you're not going to see a lot of other companies or organizations do this. And so I think it's really going to be a question of how successful these trailblazers can be and whether they can create sustainable and replicable models that other organizations are going to follow. There's certainly examples of this, but whether that can really scale across the entire industry is still to be seen.
What are some examples that just are top of mind?
Of things that have scaled well. So I'll talk about, there's a category of companies that are called enablers. So in accountable care organizations, these are provider groups that are bearing risk for full population. So the cost and quality outcomes of, anywhere from 5 to 50,000 people. And so there are companies that focus on helping organizations make this transformation. So organizations that come in and provide services and expertise and help these companies, these physician groups, or sometimes hospital systems, get the right technology, get the right protocols, get the right therapies and interventions that are there, and really start to segment and manage these populations successfully. And so there are examples of this. Alidate is one that you can go and learn about, but there have been others. Caravan Health is another. But there have been a number of these enablers that have created, basically through hard work, have learned what it takes to transform an organization. And then they go in and partner with these to be successful. I would say that does not necessarily guarantee success, but it certainly helps that. It's sort of like buying and selling a home. It's the sort of thing that most people are only going to do once or just a few times in their lives. When they do that, they go with somebody who understands it. So they work with somebody with attorneys or realtors or others that help them through that process of what it is to buy or sell a home. It's kind of the same thing, only at a bigger scale. When you're going to move towards value-based models and try to change how you structure your delivery system, how you structure your systems, how you structure your workforce, most people don't have prior experience. And so working with somebody who has done it before, that has that expertise, really can make a big difference.
Is there anything that comes to mind when you think of those organizations that outperform in their region and just do really well or make more successful transitions, other than obviously the guidance of a third party?
Yeah, I'll talk about a few different characteristics I think that are more likely to lead to success. So the first one is the organizational structure itself and how they typically get paid. So in value-based care, the traditional model is that you provide enhanced services for high-risk or vulnerable populations, and then you're able to eliminate high-cost care down the road. So it's really about prevention. So in a typical model, you segment your population, you identify people that maybe, for example, you could focus on those that have diabetes and heart failure and are at a strong risk of being admitted to the hospital. And you provide additional resources, care coordinators, interventions that are built around what those needs of that population are. And you provide enhanced care in the short term, but in the long term, that reduces the hospitalization. So a hospitalization can cost 200 times as much as a primary care visit. So you can do a lot of these primary care visits that can offset the cost of one of these hospitalizations. Now, the challenge is that at the population level, you have to do a lot of these to prevent one hospitalization because you don't know which patient might have been hospitalized, but you can be successful at that. The challenge is, can you effectively structure your organization to make the upfront investment without getting the bonus payments that come on down the road? So the challenge for hospitals in particular is that their revenue is built in patient stays. That's what's driving their revenue. And if you are saying we're going to provide enhanced outpatient care and we're going to reduce the hospitalizations, you're cannibalizing your own business. That's going to make it much more difficult for you to really create the opportunities and the interventions and the structures so that you can go and provide that care to eliminate those potential future hospitalizations. It's heads and beds. I mean, that's the model that's under fee for service. And if you don't have the heads and beds, then your income goes down. You can't say, well, we're going to make money in a year and a half when we get a bonus payment and stay viable. If you are, though, a physician group, you have a very different incentive. At a physician group, you are able to provide enhanced care coordination and case management services. You're billing in a fee for service model in the short term. So you're actually potentially increasing your revenue. And then if you eliminate hospitalizations in the long run, you're going to get a bonus payment on top of it. So that organizational structure makes a big difference. It's a lot easier for physician groups to make that change just from the dollars and cents of the financial model. Second thing that makes a really big difference for this is the ability to have organizations that adapt, change, and embrace it. So change is hard. It's always been hard. Since the dawn of humanity, it's been hard to get people to change. And it's especially hard to make changes when times are good. And in healthcare, times have generally been pretty good for a pretty long time for most healthcare providers. Yes, there are examples of physician groups and hospitals that go out of business, but they are the exception. Most have been in business for a long time and generally do pretty well financially. And when you're doing well financially, there's a reluctance to change. And so even if you have leadership that says, we're excited about it, down at a more kind of line level, people are like, whatever, we don't really care about it. And so having an organization that has the desire to change, maybe that's because they've gone through rough times and they see change as an imperative, or maybe it's more because you've got a subset of your providers that are really excited about this and they've been waiting for this their whole careers and they're going to lead the way. Whatever it is, if you have an organization that's built around this concept of change and saying we are going to do better and that's good, then that's going to set you up for success down the road. A third thing that I'll say is that you have a population that is susceptible to improvement. And what I mean by that is that you have a population that has been less well managed in the past so that you have a chance to make improvements. So, if you look at a patient group and you've got a bunch of diabetics, if all of the diabetics have uncontrolled diabetes and they have high A1C levels and they're regularly being admitted to the hospital for that, there's a significant opportunity to see that improvement. But if you have a bunch of people that are all focused on their health and, are individually tracking their own blood sugars and maintaining their diets and doing everything that they should do, it's going to be a lot harder to see the improvement that you would like. And so it's starting with a population that is far from ideal. That's another way that really leads to success.
So that's like the opposite of a lot of the criticism that I've heard about value-based care is that it increases the risk of patient selection. And so with that bias towards the healthier populations, the populations that are more empowered and able to care, to manage their conditions. But you're saying that that's actually where the most amount of opportunity is?
Yeah. So I'll talk about it from two perspectives. So one of those is imagine that you're running a mile and you're trying to make an improvement on your mile time. You get a whole bunch of people and everybody goes and runs a mile and sees what their baseline is. There's going to be a bunch of people that are, in the 12 minutes. Others are going to be in the 6 minutes and others going to be in the 18 minutes. if you're starting with a population that everybody runs a mile in 18 minutes, there's a lot more opportunity for improvement than if everybody's already running a 6-minute mile. So that's what you have when you have a poorly managed population. There is more opportunity for improvement that's there. That's just the base facts. The second part of this is that this is a critical component is the risk adjustment has to be in place. So if you just start with a population, everybody gets the same per member per month or some sort of a model like that, then it's going to be really hard to have high acuity patients. What you want is the healthy patients that never go to the hospital. So you get paid for taking care of them and they never actually need treatment. But if you're doing accurate or even decent risk adjustment, then you're going to say, well, without intervention, this is the expected cost of these patients. And if somebody has uncontrolled diabetes, it's going to be significantly higher than somebody who is healthy. And so as long as you can get that risk adjustment correct, and it actually incentivizes people to go after those higher acuity, higher risk patients, because that's where there's also more opportunity for.
Is there like a stratification of that risk, like within?
Yeah, there's a bunch of different ways that they do risk adjustment. And the primary one is looking at historical utilization. And so looking at what they've been diagnosed with, the types of procedures and care that they've received before. And then you kind of do a modeling and say, what does it go and how does it change from there if no changes were to happen external to what we're seeing. And so that's one way of it. The second type of risk stratification is what happens internal to an organization. And this is where you identify where there's opportunities for your population. And every population is different. You can't just say, oh, we're going to focus on heart failure or we're going to focus on diabetes. It really is, you have to evaluate the population that you're responsible for, identify where there's opportunities, and then create interventions custom for that population. I've heard stories about things that work really well for certain populations and others that work less well for the same kind of disease statement, but it's based on geographic location and the cultural norms within there. It's based on other factors within that population. You can't just say, look, we've got diabetics. How do we manage them? It's, well, are these diabetics that are in home environments that have supportive family that's going to help care for them, and all they really need is to be trained on how to help care for the patient, or these people that are in nursing homes, and so there's really an institutional care that's being provided, or is this people that are living by themselves without family support? You identify these other characteristics of the populations that really help you identify where the opportunities are. And that matters because let's say that you start the population and you have 2,000 diabetics. Well, maybe the real opportunity is to focus on the 50 diabetics that have uncontrolled diabetes and are living alone without familial support. That might be a very small population, but can see significant returns on the investment of resources. Other people might say, well, we don't have 50 patients. We've got 2 patients that are living alone without familial support. And so that's not the area that we're going to focus on. And so it's really understanding where you should put your resources.
So in strategizing resources, have you ever seen a case where there's maybe 2 different organizations or healthcare systems in the same locale? So theoretically, they should have the same population and the same kind of features associated with that population, but the populations are different by design?
So there are examples where you carve out population. And so you say, look, we're starting with somebody, but then we're going to segment it and actually assign different people to the different segments of that population. So an example of this is where you create a high needs clinics. So let's say that you are an organization that's responsible for 20,000 lives. You might say that there are, among those 20,000, maybe there's 150 that really have a lot of problems. And they don't all have the same problems. They just have a lot of problems, whatever they might be. Somebody might be being treated for cancer and have heart failure. Somebody else might have COPD and diabetes. And, you can go through the list and it's a bunch of these different connections. And what they've created is you say, we're going to basically carve out that subset of this population and they're going to go to a high needs clinic. You also have to identify the patients that want the high touch care. Because some of them say, no, I don't want it. So you identify where there's the need from a clinical standpoint and a desire from the patient standpoint. And then they've assigned them to a specific clinic that goes and does a lot more. They put a disproportionate number of resources toward that small subset of patients. And so that's carving it out. These are ones that are often also much better versed at working with community support organizations so that they're identifying things they could do. So if somebody needs access to Meals on Wheels or transportation or housing, they have the time and resources to put toward it. So that's where I've seen that people have segmented off from within one standard population. The other one that happens, though, is they're actually fundamentally different populations where you're in the same geographic area, the same community, but you do it by age. And that's where you recognize that you've got for example, Medicaid if you have a Medicaid population that you're managing, the pediatric population, they might still have needs, is going to be very different than your dual eligible, your Medicare and Medicaid population. And so they're segmenting by kind of age status. So that's where I've seen some other segmenting.
So, what are the biggest mistakes that organizations make when they assume that collecting more data will automatically lead to better decisions?
So the challenge with data is, how do you use it? How do you act on it? And there is a lot of data that is interesting, but how do you make data become actionable? And that's the challenge that we've seen, is that first of all, there's just the challenge of how do you collect it and knowing what you should. Then after that is how do you get the right information to the right person at the right time so they can make a decision and act on it? Really difficult. And it depends on all sorts of use cases. So one example of this is, who needs what information at the point of care? So if you are a physician and you're seeing a patient, what data do you need to see right then that will inform how you're going to treat them? Another level is, what if you're a care coordinator? You're responsible for 500 people that you need to manage and help and make sure that they're getting the right care. What sort of high-level information do you need so that you can say, well, who do I need to get on the phone with and make sure they get their annual wellness visit scheduled? And who do I need to just make sure that they've gone and seen their cardiologist? I mean, these types of things kind of vary around it. But a real challenge is that a data overload is that you give somebody so much information that they disregard all of it. And so how do you get them really what they need in a way that they can act on it and they can trust it? Because if you just give them one recommendation, then they're going to disregard that because they don't trust that. So it's how do you get sufficient information? And it's certainly a data challenge and a technology challenge, but I think more than anything else, it's a people challenge. How do you get people, work with them in a way to understand what they need, when, where, why, and how?
Do you see any challenges in like balancing patient choice and patients' rights to make the choices for themselves, but also giving enough options to where it isn't kind of my way or the highway?
Yeah, and that's always the challenge, is you have to work with the patients and know where they're at. And that's why I said earlier, there are certain patients that just don't want to be involved. That's going to be the case. There was a survey that I saw that something like 10% of people really don't trust the healthcare system and they don't want to be involved with it. There's another 5-ish% that are called activated patients, that these are people that proactively want to manage their own care, that they want to know, they're the ones that go through all sorts of different supplements and they're tracking everything and documenting it on their own. And they know exactly what's happening and they've got their own medical record that they've tracked across all doctors. That's a small number. For this survey, it was around 5%. And then you have the remainder, the 85-ish% that generally would like to do what their doctor says, but it's also maybe not their biggest priority in life. And they're not always inclined to be activated and engaged. And so you've got this range of people, and you have to know who it is that you're going to work with and when you're going to work with them. The reality is that certain people you're just never going to work with, and they're going to do their own thing. Others are going to be involved, but just non-compliant. And maybe that's something that you can work on. What are the challenges and the barriers to compliance? Sometimes it's not that they're just intentionally saying, I'm not going to take my pills, but I don't have the money to go and get my prescription filled. And that's why I'm not compliant with following that. So there's a willingness to do it, but there's some barriers. And so how do you get those barriers out? But this is, again, it's working with people. It's not working with robots. How do you work with people and meet them where they're at, provide the best possible outcomes?
I really like that you phrased it that way, because I feel like it's so much more effective to sell the outcome than it is like the process. And I think that's probably always going to be a thing, just like a human nature thing. Yeah, I guess when you talked about like those patients that want to be super informed and are super engaged, and then living in a time where we have this like hyper digitalization of healthcare. We're looking at like integrated wearable technology and remote monitoring, that kind of thing. Do you see how that could be like problematic, like having overkill of data from people that may or may not have a need for it or know what to do with it?
Certainly. I mean, it becomes, if you have too much data, then you're ignoring the important part. Wearables are a great example. What sort of information do wearables track that's actually useful, and for whom? So if you're just wearing like a Fitbit or a smartwatch, steps and sleep are useful. But is that going to influence how your doctor treats you? Maybe, but they need it distilled in a way. They can't look at, scroll through the phone and look at what your average heart rate was over time. They need to have some sort of an aggregate measure that allows them to know what to do to act upon it. So that's really the challenge, is how do you really make sense of all of this data? And that's something that I see a lot of organizations that frankly don't do very well at. which is the distillation process. Is, okay, we've collected all of this and it's available, but how do we distill it down to a level that makes sense and that people trust? That's the hard part, because if you take it too far down, then people just don't trust it. So you have to have both simple and clear and actionable, and it's hard to get all of those things with data.
We use logic to inform our decisions and justify our decisions. And I think the same could be kind of said for data, because data is kind of like what is useful is within the the eye of the beholder. Do you have a checklist or something in mind that can help listeners siphon out what's important and what's not?
Yeah, the first thing is you have to understand what you're trying to accomplish. I mean, that's the hard part, is when you have a patient population, if you don't have the goals, then you don't know what to focus on. So that's why it's useful to segment and say, this is what the goals are. And the goals are not just from the organization standpoint, but it's from the patient standpoint. So you have to use the human element to come to a consensus of what you're working toward. Once you have that, then you can start to say, these are the things that we're going to track, and these are things that we're going to measure, and that you have a sense of what those are going to be. And that's going to vary based on the patient, based on the disease state, based on all sorts of things, the intervention that you're doing. And so that will vary. I mean, some of the things that you'll measure might be process level measures. Others will be outcome level measures. Some of these will even be structural measures that you can look at. But that's what you have to do, is really to focus on that. And that's why a lot of organizations I see bite off a little bit more than they can chew, where they need to start on a narrow enough population that they can actually put sufficient resources toward it. If you try to do everything all at once, you will be overwhelmed and you won't see success anywhere. So I think that's a big part of this, is saying, let's start where we can and then grow. So it's land and expand versus trying to do all at once.
Don't wait for the conditions to be perfect and have perfect data sets.
If you're taking an organization that's moving towards value-based care, it's not something that happens overnight. You don't have an all-hands meeting and have a rah-rah speech and then you're all of a sudden a value-based organization. It is a long-term play. So when people talk about it, it's not about the first year or the 2 years or even 3 years, but it's more of looking at this over the course of a decade, the changes that you want to have. And so a big part of this is having that long-term view and being able to recognize successes and the change that has happened in the past, but also recognize just what needs to happen going forward. It's a long process.
So as you've analyzed performance among ACOs serving these high need populations like the dual eligibles, in the last 5 years, have you seen any differences or any gaps that organizations still need to address to move from sort of that equity talk to outcomes?
Sure. There's a lot. There's a lot of areas that need to be figured out. One is that organizations start internally. So if it's a hospital system, it's the hospital plus their affiliated doctors. If it's just a physician group, they start with their own practice. But it's working with a continuum of care. So how do you involve not just the physicians, but how do you involve post-acute care providers or home health providers or pharmacists or behavioral health or social workers? There's so many different people that are interacting with these patients, that how do you involve all of them and how do you stay coordinated? It's really hard to be coordinated within an organization, and it's exponentially harder to be coordinated across multiple organizations and a community. And so that's a huge opportunity to do that. Another one is, this is just a challenge with models, is they're all based on 1 year. And how do you create the incentive to make longer term investments with the population? And most of the investments that you make in the short term are not going to see an ROI, a return on the investment of time and resources, and in that 1 year time frame. And so moving towards that longer term horizon that you're focused on is difficult. I mentioned that you're trying to transform this organization on a 10-year basis, but you're being evaluated on 1 year portions. And that's really difficult. And so there's an opportunity to try to, I think people should negotiate longer term contracts, and that's what they should use as their basis to move towards value-based care.
So do you see, have you seen a decline in the adoption of value-based care or APM in general?
No, but there's been a shift. So originally, going back a decade, almost everybody who was doing this was trying to create an ACO, where they're going to take risk for a full population. What we've seen with the growth of ACOs is it's kind of stagnated a little bit. And so there's been some plateauing. And that's not because nobody's coming or going, but it's basically for every organization that joins, somebody else drops out. So that's just the reality of where we are today. And so there is an opportunity to find out why people are dropping out and trying to improve their experience so they can stay in there. Sometimes it's because people just start in there and it's a lot harder than they thought it would be. And so they say after a couple of years, we're out. Others have been in it for over a decade and they're still figuring things out. So that's one, is not all the growth though is in the ACOs. There's been an expansion into other models where you're maybe not taking full risk. So where you might be at risk for or managing a subset of the population. So maybe you're getting a upfront payment for just the primary care. So it's kind of a partial capitation model where you say you're responsible for any primary care needs but you're not going to be responsible if they end up in the hospital or anywhere else. And so there are these expansion of models that are still focused on value-based care, but a little bit less risk, a little bit less responsibility. That's where I'm seeing more growth and activity is the expansion of these for people that aren't ready to go to the full risk models.
Do you see a generational shift influencing adoption?
Yes and no. So whenever somebody's at the end of their career, I shouldn't say whenever, but the majority of people, when they're at the end of their career, they're reluctant to make changes. It's just hard. And change when you can see the finish line is really difficult for a lot of people. So there is a generational difference in that in terms of how long people want to practice. Others have been taught about value-based care in medical school. People that have graduated in the last decade, they come out of this saying, I was taught about the promise of this, but what I'm realizing is we're still in a fee-for-service world and they might be more excited about it. And so it's a range of different personalities, but this is the same thing. It's about people. And each person views the world slightly different. They have different goals and objectives. And some people go into medicine with a goal to make as much money as possible with the least amount of effort. Some people go in with the goal of saying, I want to improve as many lives and make as big of a difference in people as I possibly can. Obviously, if you've got both of those people within your organization, one type is going to be much more amenable to change than the other.
Do you think it's sort of like one or the other? Like really though, like how much of that is like false beliefs? Like, do you think that's like a limiting belief, or do you think that argument holds water? Like that you can either make money or do the right, not, I don't want to say the right thing, but you know what I mean?
Yeah, people are on a spectrum. And there's always going to be a spectrum of where people are on that. And so it's knowing where they are. There are people at the extremes. I've met them that are on the extremes of both sides, but most are somewhere in the middle. And a lot of people are kind of in the middle where they'd like, I don't want too much change, but if the change is better and it's not going to hurt my income, then that's okay. And it's hard to make major changes though, when the bulk of people are kind of in that mindset, which is we only want incremental changes and you can't do anything that impacts how I get paid. That's a pretty big roadblock in terms of moving forward, if that's how your organization views the world.
I see. So, I mean, maybe I'm just being optimistic here, but like it's almost like not even one or the other thing, but more like a tolerance. Like, how long can you tolerate that discomfort of like during that transitional process?
Yeah, I'll share an example of this. So one organization, they were a large multi-hospital system and they were moving towards value-based care. And they were starting with some of their physician groups. And what they did is they basically said, we've got, make up the number. They had like 1,500 physicians that worked for them. They said, we're going to start with the 100 that are most inclined to this. The ones that are excited about it, hungry for this, have been looking for a value-based mindset for a long time. And so what they did is they basically subsetted them and they counted how they performed different than the rest of the organization. And all these people that were excited, they were like, yeah, let's make the changes. Let's do these interventions. And they were successful. They actually made a lot of money in bonus payments and they were able to give them back to the physicians. And then the next year, there's another tranche of people who say, I saw that they were successful. I heard about these bonus payments that they were getting. I want to join in as well. And so you can start with the true believers, prove it out, and then expand from there. Obviously, that depends on the organization. If you've only got 20 doctors in your whole organization, you can't just start with the 10%, the 2 that really care about it and try to prove things out. And so it depends on the organization, what you can do. But starting with those that believe, see their success and building on that can be a winning strategy. The other side of the coin, though, is if the true believers go in and it's harder than they thought it was and they're not successful financially, then that could lead to the whole organization pulling back from it. And that can also happen. And I think the reason for that is that the first year, I think success is more luck than anything else because everybody's going to try hard, but it's trying a whole bunch of things and seeing what works. And what you focus on in the first year may not be what works. And so with organizations, they really need to commit 3 years to it before they even do their first evaluation. Like you've really got to put the time and the effort into trying a bunch of different things. And then you can make a more informed decision about whether this is likely to be successful for you as an organization.
How have you seen social determinants of health integration in the last 5 years work out?
Mixed. So certainly there's a need. Everybody recognizes this is like if you have a patient that doesn't have transportation, doesn't have access to food, doesn't have community support, they're going to have worse outcomes. And the doctor in the office is not going to be the one who's able to solve all of those needs. And so they say, well, how are we going to address some of those needs? And so I've seen a couple different ways that happen. The one is you have social workers or other care coordinators that are embedded within the practice that can help with some of that. And that can be productive and it can be useful. The hard part is really proving the ROI for that, because you have fixed costs for those caregivers without necessarily a guaranteed return on that investment in the short term, at least. So I've seen that. Other organizations say, well, let's just try to partner with these other entities in the community and make referrals and try to direct people to them. And that has mixed results. If you've got a community that has a strong service-oriented organization that I should say services oriented, that knows all of the different community services that are available, it can kind of provide that connector capability, that's great. A lot of communities don't have that, where there's a service there and something there, and you kind of know about it by word of mouth, and nobody really is centralized. It's really hard to connect with the community in that standpoint. So it really depends on the community and the organization and where they're at and what you can build from. Some have done a lot more than others. Unfortunately, I've seen many that have a long way to go.
I see. Do you see any connection between adoption of APMs and the availability of social care infrastructure?
Not really. When people are looking at it, that is a secondary evaluation. First, they're looking at it from, do we have the organizational interest in doing it and doing the financial models? And then afterwards, it's like, oh, what are our needs and who are we going to work with for it? And so that's not driving it initially.
Should it?
I think it should inform them, but it's sort of like if you're trying to build a house, you need a very first evaluation of the site plan before you start talking to the electricians. And that's where it is you have to do that kind of high level. So you really need to go through the stepwise evaluation. I think organizations would benefit by spending a little bit more time on the planning. So they in the analogy of building a house, they get a site plan and say, oh, we can build a house, let's jump into it. It's like, well, maybe you should actually have the architect come in and then maybe have the electricians come in before you go and start the build phase. So it needs to be involved at some point earlier on than it is today.
Okay. Well, that's fair. What are some other factors that just surface level that some organizations should look at before considering taking on this kind of model?
Understanding what the business community or dynamic is like within their community is certainly an important part of this, because if all of their competitors are moving toward this and the payers in their market are moving toward this, then they're likely going to be forced. And it's a lot easier to do it when it's voluntary than when you're being told exactly what to do. And so just being aware of kind of how their market is shifting is something to take into effect. I think another thing to look at is what technology they're going to need to be able to manage these populations and what the costs are for that. A lot of people I've seen both overestimate and underestimate the cost of technology. Some people already can just use what they've got today, and others have major needs that they need to invest in. There's one organization that was made up of a bunch of different physician groups, and they had something like 80 different EMR when you count the different versions of those. And it's like, if you can't even message each other across from like primary care to specialist, how are you going to have coordinated care? And so that's what they spent a lot of their first time, was just how do we bridge all of these disparate systems? Other people are coming from, an academic medical center that has Epic across the board. And from day one, they're able to communicate. And so it's a very different environment. And so it's requiring organizations to really take an honest look of where they are as an organization, what their needs, what their strengths are, and what their opportunities are. So know what your market is, know what you can do, and doing an upfront and honest assessment, I think are things that people really need to spend a lot of time on. That will set them up for success if they have an honest assessment of where they are and where they might be able to go.
In that dynamic, how much should a hospital partner and be involved with and help build up community infrastructure?
So they need to be involved and aware of it. Now, the question is what role they play. That's going to depend heavily on the community that they're in. I have seen hospital systems that have taken the lead on some of this. Traditionally, though, they can only do this if they are doing really well financially, because it is a burden. It takes a lot of time and effort. Other times, I've seen them participate in things that already exist within that community. So it's doing that. I mean, every hospital is supposed to do their community health needs assessment, where they go in and say, what are the needs that are here? And so that they're aware of what's going on. Really look at that and say, how do we participate then? Do we need to lead something? Do we need to start something? Maybe it's sufficient to give, a pot of money to set up something, and then it's going to run on its own. Other times you might need to lead whatever that might be, but it's a lot of time and effort to make it happen. And that's, I think, a challenge, is that most hospitals, they say that they would generally support it, but they have so many other things that they're focused on that they just aren't able to put in sufficient capital. And by capital, it's not the money so much as it is the people's efforts that they're able to go and make it be successful. I think that's the challenge, that to do any of this, you have to invest time for the long run. And it's hard to do that.
So based on all of your research and work, is it fair to say that increasing participation is not just an issue of payment redesign, but maybe reimagining who we incentivize and how we define performance?
Yeah. So the way that I think about it is that there is payment reform, and that's hard. There is delivery reform, and that's hard. And then there's cultural reform, and that's hardest. You have to get all three of these things lined up and happening concurrently, and you can't do any of them from a single perspective. Maybe you can do federal things and do payment reform, and maybe you can have best practices that will come in that will help with delivery reform, but then the cultural side is going to happen within the organization. So you've got to have all three of those things kind of aligned, and that's what makes it so difficult. Getting any one is hard. Getting all three at the same time is really challenging, but that's what's needed.
What have you seen in the successful versus unsuccessful iterations of that?
It's commitment. It's getting commitment from day one and say that this is going to be long, and then you have leadership that continues to focus on that. So one of the things that I found is that if you ask some executives and say, what are your priorities for next year? And they say, well, we're going to do more with value-based care. We're going to do better with our contracting. We're going to do better with AI and do these things. It was actually a trick question, because the answer is if you say multiple things, you don't have a priority. And that means that's not going to be your focus. And that's the challenge with value-based care, is if that is not your focus about redesigning your organization, then you're not going to redesign it. You can do a lot of things to improve things around the edges, but really moving to value-based care where you're proactively managing populations and keeping them healthy is not just an add-on to a fee-for-service chassis. It is a fundamental redesign of how the organization operates. And so the people that really are successful are the ones that say we are all in on this. And they create the financial models that allow them to be successful and succeed when they make that transformation. And that's hard and it's risky. And that's why a lot of organizations just don't do it. They dabble around the edges. And yes, they can make some improvements, but they're not going to fundamentally change the organization itself.
Is there, like, if we were to say, like, if you were in the shoes of like any hospital, like healthcare system executive, leader, how much of a priority should it be?
So what I would do is I would talk to the board. So if I was a believer that we should move to value-based care, and I'm a believer that organizations should do that, I would get the board aligned and say, this is what we need to do, and help make it crystal clear that this is a long-term investment and it's going to be challenging, and there are going to be hiccups along the way, and you just expect that. There will be times when the revenue is declining or the market share is declining, or there might be news stories that are negative that come out. You say, this is all going to happen because this is a radical transformation of the company. You find out if the board is aligned. You don't have alignment with the board, it's never going to work. But if the board is fully aligned, then you then go to senior leadership and make sure that your senior leadership at all, I would say, like the C-suite level, but also probably 1 to 2 levels down, at least 1 level down, and maybe 2 in some situations, that those people are aligned as well, that they're true believers in this. If they're not true believers and you've got the board behind you, you can start to change those people over time and replace them with true believers. But if you don't have true believers that say this is our focus, not like one of many priorities, but this is our focus, then it's not going to be successful. At that point, when you've laid the ground, that's when you start to move into actually executing on it. Now, for most organizations, this is not going to be the case. You're not going to get the board fully aligned. And even if you do, you're not going to have the leadership that's all aligned around that. You might not be able to change some of that leadership given those organizational dynamics. That's the reality for most provider groups. What I would recommend in that case is you say, if you're still the believer on this, you start pilot programs where you get subsets of your organization and you treat them in a different way than you do the full organization, and basically try to let them build out a value-based model in almost in a separate company, almost, so that they have flexibility to do things very differently, where they're being evaluated differently, they're getting paid differently, they're hiring differently. That way, the time when the market conditions are right, either because government is mandating this, or the payers in the market are, or because fee-for-service payments have dropped and you need to make a change, then you say, we have already validated this. We've learned some of those hard lessons. Now let's try to expand that to the rest of the company. That's why I think a lot of organizations are just doing these small scale pilot programs, because they don't have that full buy-in. Really, the way that you get the buy-in is if there's no alternative. If the organization is going to fail, under fee for service. But as I mentioned before, most organizations are not near failure under fee-for-service. And there's not that burning platform that's driving the change.
That just reminded me of that Rules for War, I think it was by Robert Greene, where he talks about burning the boats, like where you can't have an escape, and because
Yep,
if you
you're all in.
do,
It's either
yeah,
success or failure. Either we succeed in value-based care or the company goes into bankruptcy. I mean, if it's not at that level of focus, it's hard to change it. It's really hard to change a business model. And that's what this is. It's a fundamental rethinking of the business model. So the example that I use is, imagine that you're at McDonald's and you're the head of McDonald's and you say, we have grown all we can in fast food, and so we want to make a pivot into fine dining. And you look at McDonald's and you realize, well, it's the wrong brand. People don't think of McDonald's and think fine dining. It's the wrong locations, because where McDonald's restaurants are is not where you want a fine dining restaurant. They have the wrong facilities. You can't just take out a play place and put in a tablecloths covered tables and do things. You have the wrong supply chain, you have the wrong staffing, you have the wrong technology. Absolutely everything is wrong. And that's why McDonald's is never going to transform from fast food into fine dining. If they were to do it, they would create a new brand and get new facilities and do it completely separate from their core fast. I think that transforming from a fee-for-service driven system to a value-based care focused system is a bigger transformation than McDonald's going from fast food to fine dining.
wow.
That's the level of change that it really is. And that's why it's hard. Unless there's something that's saying either do this or not, there are going to be very few organizations that proactively do it. So that's why, if leaders believe in it, that's why they create the experience in a subsidiary. They learn it so that they're able to scale it over time when the moment is right, when the platform is burning, and that's when they say we have to make a change. It's not going to be done just naturally because it's too big of a change.
I just wanted to ask if you found this video insightful. And if you did, please click on subscribe so that we can continue to ensure no one gets left behind in the value-based future of healthcare.
So opting in when the timing is right versus waiting for it to come to them, it almost sounds like it's inevitable. This is what it's going to be.
Yeah, and that's where I don't know that it is. I hope that it is, but I don't know that it's inevitable. Fee-for-service has proven to be very resilient. That's why there's a risk. And when somebody says it, and I've spoken with organizations that have looked at this and said, we know what it would take to make this transformation, and it's just not worth the risk right now. I've seen that, and I fully respect that, because if I were in that situation, I might make the same conclusion, because there is what happens. And I've seen this happen with a company before, where they say we are all in, we're making all of these changes, and they cannot figure out the financing and the payment models to make it work. And they've gone out of business. They literally went bankrupt because of it. That's the risk that's there, and it's a real risk. And so I don't fault organizations for making that decision. But if we want value-based care to really achieve its promise, we're going to have to see organizations that really do make that transformation. That's why it's hard, and that's why it's not a 1 or 2 or 5 year change. This is a decade or decades transformation to take place for our healthcare system.
You've also worked at the intersection of price transparency and value-based care. And based on what you're seeing today, do you feel healthcare is genuinely becoming more consumer-driven, or are there still major barriers to true competition?
Not consumer-driven. So I think price transparency will apply to a small subset of services for a small subset of patients where they're going to do it from a consumer level. Where I do think there's a lot more opportunity is where organizations start to leverage that. So an example of this is, let's pretend that you're a primary care practice, that you're managing a population, you're at risk for them, and you're really trying to do things effectively, and somebody needs a knee replacement. Where do you send them? Price transparency helps to identify who the high value providers are. If you couple that with quality information, you can say, look, these are the doctors that I would recommend because it's going to get the outcomes that we want, and they are significantly lower price. And there's a huge spread in just the pricing side of this, where could be a 3x difference. So you go to one provider and it's $20,000. If you go to somebody else, it's $60,000. And those are real numbers. And so if you incentivize people to go to the higher value, so better quality and lower cost providers, that will do 2 things. One, you'll pay shorter or lower amounts in the short term. Second is, if you can shift volume away from either the high cost or the low quality or both providers, you will make them change. And when somebody used to operate 3 days a week and now is only operating 1.5 days a week, and they're like, why can't I get any patients? And someone says it's because you have low quality and you are expensive. That's an incentive to change. They're going to change in a way that they wouldn't if, Medicare is going to do a 5% withholding on payments. So that's where I think there's that opportunity, is that as you direct people to the high value providers, that can move the market in a way that these other payment models just can't.
Oh, this has been so awesome. Are there any ethical considerations within that price transparency?
I don't know necessarily with price transparency. There are ethical considerations just in general around stinting on care and making sure that people get the care they need. Now, the challenge with this is that there can be good faith disagreements about what care is needed. And that's always going to be a challenge that's there. But if you have a culture that is responsible, that is responsive to the patient needs, and you also have the ability to say, look, part of what we're doing is trying to ensure that we have patient satisfaction and we are being measured for the outcomes that we generate, then I think that will take care of itself. So I think that you do need to be aware of it, but I don't think it's going to be as big of an issue as in other areas of health.
Like what other areas?
I mean, like AI, I think there's more challenges with AI, for example.
Yeah, okay.
Like that. Yeah. There's other topics that you need to be more attuned to the ethics of it than I think you do with value-based care. Because value-based care, as long as you are responsible for the outcomes as well as the cost, that should be aligned with, in most cases, with the patient's desires as well.
Yeah, it's a tricky one because like just I'm speaking this is maybe apples and oranges, but it's there as a frontline social worker, there's been so many times when I've referred to somebody to like a home health agency or like an aftercare, like kind of discharge facility or agency or whatever that I know is not as quality, but I have to because of like certain things that we can't guide you. We can't tell patients which ones are the good ones, which ones are the bad ones, even if we know that they're not, even if I get feedback from, like other patients or just like in my role. And it's just does become this frustrating thing of like, yes, I have an ethical duty to acknowledge and provide choice and that kind of thing, but also have an ethical duty to not direct patients towards substandard care.
Yeah. And this is where a thing that can be improved to help for that is where you actually have trusted, reliable data that helps people make these decisions. If somebody can look at the data and trust it, I mean, that's the hard part. But if they trust the data and be like, look, the quality is better here and the prices are lower, then most people will say that makes sense. Now, there will be times when they don't make that choice, but I think that's a part of that data side that you brought up earlier that needs to be improved is how do you get them the right information they need at the time they're making a decision when they have to make that decision.
Well, thanks for letting me sneak in that last part there, but
Yeah.
thanks again for sharing your expertise. This conversation will absolutely stay with our audience, and I appreciate your time and your
Yeah.
leadership.
Yeah. It was great chatting.